Hello, everybody. Welcome to this edition of Cameroon Town Hall for Healthcare Professionals. It's a pleasure having those who have already tuned in. If you are tuning in for the first time, this is a platform that brings together healthcare professionals from Cameroon spread across different countries. We gather every fortnight to have a conversation on different topics of public health interest to Cameroon and to exchange knowledge and ideas on how we can better improve the healthcare system in Cameroon. So far, our number keeps growing. We now have a total number of around 1,755 members who have at least attended one of our sessions, and we have all this coming from about 35 countries. And so we are very glad to have you here today. We want to thank all the moderators who have tuned in already. I will be moderating this session with Dr. Brian Tegomo, who is in Nebraska. Brian, hello.
Yeah, hi, Elvis. Really excited about today's discussion, and it's really good to see you, Sidney, and welcome. Really looking forward to hearing as much about this field as possible. I know the incidence of cancer is really rising in Africa, and the need for that intersection between artificial intelligence and radiosurgery is becoming so critical now. So really looking forward to hearing as much from your field as possible. So thanks a lot, and over to you, Elvis.
Thank you very much, Brian. It's really going to be an exciting session today. We have also other co-moderators. We have Dr. Weah Allison. We have Christelle from Cameroon. Allison is from Seattle and Washington, and we also have Christelle also from Seattle. I think they will be joining us as the session unfolds. And before I tell you the topic we are going to have today, let us hear from our chair. Hi, Mono, welcome from you.
Well, thank you, Elvis, and it's always a pleasure. So the goal of the town hall, as you all know, is for us to educate ourselves. Today is a topic that I hold dear to me, and so Sidney is going to do a good job for us to see the way forward back home. Practically, what can we do? And last week was World Cancer Day. We spoke about this. This was like an emergency topic that I had to call on him so that we get this discussion going and make good use of this World Cancer Day week so that we can be able to enlighten and shine some light really on cancer in Cameroon and in Africa. It's a neglected disease in Cameroon. So I would just group all of it, call it a neglected. It's made up of multiple things, but it's neglected, and there is no funding, and there is no awareness. There is even no screening guidelines for any of the cancers, maybe except for cervical cancer. It's really where healthcare needs to go at the moment. We're having an dual epidemiological crisis going on in Africa, chronic diseases, infectious diseases, cancers, and all of this change in lifestyle. We've adopted all the lifestyles of our colonial masters: smoking, alcohol consumption, infections that can cause cancer. So there's everything going on. Thank you, Elvis.
This must be a very exciting topic for you as a hemato-oncologist. So I understand how passionate today will be for you, Dr. Muno. Thanks so much for your words of welcome. And today the topic is going to be improving cancer care and reducing mortality in Cameroon. What can be done today? And our expert is going to be Sidney Tazeh. who is going to really spend time to give us, a lot about what he's doing in the field of radiation oncology as a physicist. And before we even get to know who Sidney is, I also want to acknowledge the fact that we have today in our midst Dr. Yauba Seydou, who is a country director of the Clinton Health Access Initiative in Cameroon, and he's doing some really great work with the government of Cameroon just to promote access to cancer medications to patients in Cameroon. And I'm sure he's going to also really have some good insights at the end of the presentation. Normally, if you're attending for the first time, we always consecrate the first 1 hour to our guest speaker who goes through a presentation. We all listen and take notes of our questions. And after the presentation, we have a question and answer session, which is that moment when we interact and share knowledge. So please, if you listen to the presentation and you have any question, you can jot them down and wait for the moment when we get to the question and answer session. Once again, thank you so much for dialing in, and I'll hand the floor over to Brian to just read the bio of our guest. He said, please, I don't want you to say so much about me, and we begged him for a really good bio, but he sent 2 paragraphs. Nonetheless, you are who you are. We know you. We will find you on LinkedIn. Brian, please tell us who Sidney Tazeh is.
Yeah, absolutely. And thanks a lot. I just want to commend Sidney for all the really amazing work that he's been doing over the last 2 decades in this specific field. So Sidney Tazeh, he's a radiation oncology physicist from Florida. He's board certified by the American Board of Radiology and has been practicing medical physics in the US for the past 15 years. He's an expert in a field that I'm hoping to learn more about today called cyberknife robotic radiosurgery, and he specializes in the use of high-dose radiotherapy for brain and spinal cord cancers and lung cancers as well. In 2017, he was a lead medical physicist in setting up the radio surgery program at Tampa VA Hospital, which is among the top 5 radiation therapy centers for veterans in the federal government of the United States. And he's been extremely passionate about global health, and he's doing a lot of work in Cameroon as well, and really advancing the specific field of radiophysics in Africa, and particularly in Cameroon, how we can really revitalize radiation therapy in our context. So we are really, really thrilled and extremely honored to have Sidney with us today. So I really look forward to his remarks and his presentation. Sidney, take it away.
Yeah, thank you, Brian, and thank you for that brief introduction. And while Sidney is preparing to put his slide on, Christelle, je vous vois, vous êtes dans la salle. Bonjour.
Bonjour Elvis, bonjour à tout le monde, bonsoir, en fonction de où vous nous joignez. C'est un honneur de rejoindre l'édition ce soir. Merci à Sidney d'avoir accepté l'invitation pour ce soir. À toi la parole, Elvis.
Merci beaucoup, Christelle. Christelle is one of our moderators, dialing in from Cameroon. Thank you for being part of the session today, Christelle. And over to you, Sidney.
Yes, thanks, Brian. Thanks, Elvis. Thanks, Muno. It's a pleasure to be here this afternoon, Saturday afternoon. It's a busy Saturday afternoon. I acknowledge it's a holiday in Cameroon, and it's also the day before the Super Bowl in the USA. So I think everybody's in the festive mood this weekend. So I'm glad to be here. And yes, I'm going to be giving a talk on things that we can do today to get in front of this scourge. I call it a scourge because it's a problem that is increasing every day when it comes to cancer care in Cameroon. And my hope is that this is the first of many talks that I'm going to give on this forum, because I see us, what we're doing here is going to make a big impact in how we take cancer to the next level in Cameroon. So I'm looking forward to the talk today, but more especially, I'm looking forward to coming back here at the town hall. So thanks, Brian, for that introduction. Yes, I'm a medical physicist by training, and been doing a lot of work on global health. And when Muno told me about this, it's a very timely topic, because like Muno said, it's an international World Cancer Awareness Month. Actually, February 4th was World Cancer Day. So I'm going to go ahead and get started here with my slides. Probably should take about maybe, I don't know, we'll see about 20, 25 minutes, depending on how fast we move, but I'm excited. So, all right. So, can you guys see my screen?
Yes, perfectly.
Okay, give me a second here. I expected to see a. Okay, all right. Give me a second. Let me minimize that. All right. So, yeah. So I'm gonna try to keep this talk as I know we have a wide variety of professionals here, from cancer experts who do it day in and day out, to general practitioners, to just other healthcare IT. But everybody here who's on this forum today is clearly interested in making a difference in cancer care in Cameroon. So I'm gonna try to keep my talk, make it as practical as possible, because we know about the problems in Cameroon. We know the issues with cancer care, and rather than just pointing out those issues, we're gonna try to start talking about solutions. And like I said, this is very timely. So this year, the theme for World Cancer Day there were 3 themes that they put together. And one of the themes was bridging the care gap. What things can we do to help the amount of care that we provide in Cameroon, and see how that can get closer to what we've been spoiled in the US, because we know we get very good cancer care in the US, in Europe, and all of our developed countries. So everyone deserves access to cancer care, right? So that's the other theme. And then obviously uniting our voices and taking action. I don't know who came up with these three themes, but I think that it gives a full picture of what we need to be focusing on in order to improve cancer care in Cameroon and Africa in general. So, so this World Cancer Day, the question I'm asking everybody on this forum today is, what things can you do to bridge? Hello. Can you guys see my screen?
Yes, we can see your screen.
I want to make sure you're seeing the right screen here. Give me a second. Let me switch this. So the screen you're seeing, does it have multiple slides at the same time, or is it just one slide?
It's one slide, the World Cancer Day.
Okay.
What will you do to close the gap in the cancer care?
Okay, perfect.
Yeah, I think we're seeing the right screen.
All right, perfect. All right, just give me a second. I might go ahead and switch this a little, just. All right, so this World Cancer Day, what can you do to bridge that gap, right? And every medical professional on here, I'm hoping that by the time we're done, you can learn at least one way that you can do today. So to begin with, I'm going to start by my disclosures. I'm the founder of Clear Medical Foundation in Cameroon, and I'm also the founder of Clear Radiology. And my slides today are my professional opinion. Obviously, I've been in the field for a long time, and there's a lot of published data on things that can be done. So I'm going to share with you some of that knowledge that I've garnered over time. So this talk will focus on we'll talk on cancer prevention in general, cancer screening in general, cancer diagnosis and management, because these are the 4 pillars of how you can successfully handle cancer in Cameroon and West Africa. But word of caution, like while I'm going through this slide, it's a lesson in life where we should try our best to not let the perfect be the enemy of the good, right? Things I'm going to tell you guys today are things that can be done today, tomorrow, in the next 1, 2, 3, 4, 5 years. They are not perfect solutions. Cameroon is not a perfect country. We have limited resources, but we have to learn to be able to make a difference given the resources that we have at our disposal. And there's a lot of recommendations out there on how we can go about this in a low resource country like Cameroon. So why do we care so much about cancer? Well, if anybody has done any research or any literature search in the last year or two, there's a lot of publications about the scourge. There's a study from Penn State that shows that cancer deaths would double by 2040, would double. And there's a Cameroonian physicist, his name is Dr. Ngwa. He is doing a lot of work with Rutgers Global Health. and they are raising their alarm bells. They are raising the alarm bells that sub-Saharan Africa in particular, it's at the forefront of this increase in breast cancer cases, lung cancer cases, prostate cancer cases. And why is that? Simple reasons. We are beginning to live longer, right? We're living longer, and of course, age is the #1 risk factor for cancer. So because we're living longer, then we're getting more people living with cancer and people who are dying of cancer. And of course, the other reason is urbanization, right? With urbanization, we're not exercising as much as we used to. We're not eating as healthy as we used to. So that is the simple reasons why cancer death and mortality and mobility are going up and up in Cameroon. And this is very, very crazy, because us as Africans, we actually have a low risk for developing cancer, because compared to the developed world, like you said, we eat healthier. So why are we not having the survival that we think we should be getting? Because obviously we're not getting that many cancers. A lot has to do with the socioeconomic factors, the political factors, the financial our resources that are available to us. So the reason why we care so much about cancer is that many cancers diagnosed early is curable. And this is one thing that I'm going to stress on, right? Breast cancer, skin cancer, lung cancer, prostate cancer, many of these cancers are curable. So if you know something is curable, why not do everything you can to focus on bringing access and resources to that ailment? But reason #2 is that we live in a low resource setting, right? Where it is even more important that we diagnose these cancers early, because in the USA, in London, in Britain, in Australia, they can treat stage 1, stage 2, stage 3 cancers very well. In Cameroon, stage 1 cancer is one thing that I know that we can handle in an acceptable way. But once you start getting to stage 2, stage 3, stage 4, then it's even harder, right? It's harder to deal with. That is why we care about cancer at this point. A lot of people will say, well, hey, but Sidney, there are other diseases that have high mortality. And that's true. Many diseases have high mortality. But cancer has this socioeconomic and cultural impact in society that is very high, right? Talking about body image, talking about social stigma, family concerns. So because of that, we put a lot of emphasis on cancer, because somebody who dies from cancer and somebody who dies from, say, heart disease, our society, especially in West Africa, we handle them separately. So I'm going to pose this question to the town hall. Which has a higher negative psychological impact, right, in society? Because cancer is not just the death, but it's also the burden, right? Which has the highest psychological impact on the society? A plane crash that happens once every 6 months or once every year and kills 50 people, or a car accident? A car accident, maybe we'll have a few a day, but we got them every day. Car accidents kill more people than plane crashes, but plane crashes have a more significant impact on society because of that. It strikes fear in us, and so cancer does the same thing, right? Despite the fact that we have other illnesses, cancer is like a plane crash where people are really concerned about it. But even then, we still know that cancer deaths are on the rise. Why do we care so much about this? We can make a difference. I looked at this case in Botswana, where one country showed a path on how we can make a difference in cancer screening, cancer care. In Botswana, when HIV hit Botswana in the late 90s, early 2000s, Botswana was getting devastated, and they laser focused on care for HIV and AIDS, and sensitization, screening, medication. And once they were laser focused on that, and the role that is massive rollout, which was, again, like I said, enrolling people, trying to get people to believe that HIV was real, there was a nosedive. Cancer in Africa, the way it's coming in Africa today, I think of the AIDS pandemic, because it is increasing significantly and it's catching us unaware. There are so many publications in the last 2-3 years. Go 5 years ago, 6 years ago, you're not going to see many publications. But in the last 2-3 years, there's a lot of publications about cancer incidents in West Africa and Africa in general. We can begin in one country and we can show how it can be done. And why not Cameroon? Cameroonians, we are smart, and we have the experts, and we have the knowledge and the tools to actually make a difference. And I want to thank this town hall, Dr. Mono and his group for getting this town hall started, because this is a prime example where we can really make a difference in this town hall. So today I'm going to talk about very briefly as much. Obviously, cancer, we can take one weekend and only talk about lung cancer. So obviously, I'm not going to go through all the cancers, but I'll give you some practical things that can be done today. Being somebody who's been to Cameroon many times, seeing how things are being done in Cameroon, and talking to other professionals in Ghana, in Nigeria, I think I have an insight onto changes that we can make in Cameroon today. So we're going to look at lung cancer, breast cancer, and then just mention prostate cancer and mention cervical cancer, because those are things that are obviously a burden in Africa right now. Again, look at prevention, screening, accurate diagnosis, and then staging. Obviously, you cannot treat somebody with cancer without right staging. But again, we are not going to let the good be we're not going to let the perfect be the enemy of the good. And then, of course, you do all of steps 1, 2, 3 in order to manage that patient. But remember that step 1 is probably the easiest. It's the low-hanging fruit, right? Prevention. As you go from step 1 to step 4, things start getting harder and harder. Prevention, everyone is involved. Everyone. Screening, you need more expertise because now you start getting to more skills. Staging and diagnosis, then now that's what I'm talking about. There are fewer facilities that can offer that. And when it comes to management, there are even fewer hospitals. So that is why it's important that we laser focus on steps 1 and 2, prevention and screening, because we know that we don't have that resources that America or Britain or Australia has. We have to. Very important. What is the goal, right? It's important. When you set out to do something, you got to find out, why am I doing this? Okay. Obviously, reduce mortality. And then, and what does that mean? We want to reduce deaths from cancer. Number 2, reduce the burden. That's the end point. And what does that mean? We want to reduce suffering. And then, obviously, when you go to manage somebody, are you trying to be curative or are you trying to be palliative? And the reason this is very important, and I'm going to talk about this in my next few slides, is that when the physicians out in Cameroon and the medical practitioners tell the patient the goal, or they have a clear goal of what that intervention is going to be, then it avoids unnecessary surgeries or unnecessary intervention. This is very important. This is very important. The intent has to be stated from the get-go. So first thing that we can do today, lung cancer. So I'm going to start with lung cancer. What can the physician who is at the town hall today, Dr. Niba or Dr. Agbo or Dr. whoever is in Betua on Gaundere, prevention. Doctors in Cameroon, we should be taking full advantage of wellness or sickness visit. Okay. In the USA, that's something that is done very well. It's a low-hanging fruit. It's easy to do. When patients come in, that's when they have the doctor, the patient attention. Okay. Talk to them. Ask them about your health. Tell them. Talk to them about cancer, lung cancer, prostate cancer, breast cancer. Ask them how things that are doing to reduce your risk. That is where everything starts. We're not reinventing the wheel, right? Take advantage of when that patient is in front of you. I was very surprised when I moved to the US and I went and saw about 10 years ago, when I saw my doctor, and he was asking me about my life at home. How was my stress at home? How was my stress at work? I was like, why do you care? Well, because that's how you start that conversation. So this is something that I call on my doctors in Cameroon that they can start doing right now. When somebody comes with an abscess, you can take that advantage. A lady, 29 or 39-year-old lady, start talking to them about breast cancer. Or a guy who's smoking, start talking to them about smoking. Another thing that you can do in the wellness visit for lung cancer in particular, stop smoking. We cannot emphasize this enough. In the USA, it has worked really well because they've used scared tactics. I haven't seen this in Cameroon as much, but we need to double down. Scared tactics work. People need to know that lung cancer is real and smoking is the worst thing that has ever happened in the history of medicine, as far as the causing morbidities and deaths in the world. On those wellness visits, talk to your patients about them, ask them to stop smoking. 1 cigarette a day would increase the risk by 64% from dying early. It would increase the risk. So smoking is the #1 thing that we have to do in Cameroon and Africa, and it's not secret. When you look at the USA, right? Look at what happened when they decided to start emphasizing the banned cigarettes and the sensitized people. And beginning around the 1960s, cigarette consumption, the sale of cigarettes started going down, and it was followed immediately by the rate of lung cancer death. That was like the most easiest thing that we could have done. And cigarette smoking, not only, of course, cancer is not the only thing that cigarette does to you, but from heart disease to brain aneurysms. Even food, right? People who stop smoking say that a month after they stop smoking, food just tastes better. So quit smoking. Make sure you have that discussion. You have to be purposeful about it when your patient comes to see you for a headache or a fever or a malaria. Have them, talk to them, especially if you know they are smoking. The cigarette is the deadliest object in the history of human civilization. That is what the NIH has put out. Here's another thing about smoking truth for cancer, right? As a cyberknife radiation oncology physicist, right? I tell my uncles in Cameroon that I treat a lot of patients with cancer. But if you smoke, the cyberknife has nothing, the cyberknife cannot help you. We do not treat people who have cancers that are caused by smoking on the cyberknife. So it's a tool that is out there, it's a magnificent tool, but if you're smoking, sorry, you're out of luck. So scare tactics work. Let our doctors in Cameroon talk to patients and remind them that these cancers are preventable. Screen for lung cancer. Obviously, screening for lung cancer, low-dose CT is something that is being done here in the US. It's the only way you can screen for lung cancer. So after you've tried to prevent, then you look at people who are high risk, because obviously screening, you can't screen everybody. But of course, low-dose CT, for those who don't know, it's a simple diagnostic test that uses very, very low dose of radiation to catch those early cancers. Unfortunately, low-dose CTs, that's not feasible in Cameroon. We have CT scanners in Cameroon, but guess what? We cannot be using them to screen a lot of people because we'd rather use it. There are other things that we have to focus on. So it's not feasible. But what is in Cameroon? We have X-rays. Okay, at least that is present in Cameroon. There's still a lot of room to go, but that's something that we can use. Everybody knows of mammography for breast cancer. Well, do you know that you can use basic X-rays to screen for lung cancers for people who have high risk? It's feasible in Cameroon. However, there can be many false positives. I think somebody needs to. The lung cancer screening, there can be many false positives, and it's very dependent on the radiologist. So is there a way around that? Because we do have the X-ray machines and the X-ray technologies to do it. How can we use that to help screen for lung cancers? Well, there's a solution out there. So if you saw a mass on a CT scan, is it benign? Is it cancerous? Or you saw a mass on an X-ray, is it benign? Is it cancerous? Well, the doctor in Cameroon might not know how to approach this problem. But of course, staging is important. You have to know whether that mass is benign or cancerous. So, right, you have to get a biopsy. Well, hey, that's not an option in Cameroon. Why? Because we don't have IR specialists who can do biopsies. PET scan. You need a PET scan the lung lesion will light up. For those who don't know what a PET scan is, the patient comes in, they inject them with a radioactive substance, and then the patient literally lights up like a Christmas tree. Any cancers in the body will show up. It's the easiest way. Even a 2-year-old can look at it and say, oh, there's something that is not right. But PET scans, of course, is an indispensable tool for diagnosing cancers, right? And staging cancers. But again, it's not a tool that we have in Cameroon. It's not an option. Look at Nigeria, for example. Nigeria just got the first PET scan in February, like last week. Nigeria got the first PET scan. So we know it's not an option. I'm going to give you an option for our clinicians in Cameroon. Mayo Clinic has something they call the Mayo Clinic Long Nodule Calculator. And what it is to help physicians who want to have a quick, accurate way of being able to do that initial staging or initial workup for a patient who they find a suspicious lung nodule on CT or the suspicious lung nodule on X-ray. And that calculator looks like, let's go back. Oh. So can you guys still see my screen?
Yes.
Okay, yes. So sorry, let's go ahead and look at what that calculator can do for our physicians back home, how they can use that to assess a patient who has The Mayo Clinic calculator. Just give me a second. I think I lost my share there. All right. So lung cancer. So things that you can do right now for a physician in Cameroon. Now, obviously, this full disclosure, this calculator is not something that anybody can just grab and use nilly-nilly, right? You need some training, but it is basic. If you are a trained medical professional, you can go online right now. If you have the right X-ray scan done or a CT data set that the radiologist gave you a report, you can at least have an idea to be able to say, oh, there's this 90% chance that this patient has a lung cancer. So I'm going to go ahead and pull up that calculator here for a minute, and then that way we can all see. So give me a second there. All right. All right. So this is from Mayo Clinic, and Moffitt Cancer Center, which is my neighbor here, they are doing a very good job with lung cancer screening. They have a screening program where they are going out and they're educating physicians so that physicians can identify patients that are higher risk. And it goes back to that wellness visit. Moffitt is reminding physicians that take advantage of a wellness visit. So let's say it's a 75-year-old gentleman who comes in, 75 years old, and then on CT, if you have a CT scan, which we do have in Cameroon, or even on an X-ray, they have a noodle that is 25 millimeters, right? Are they former smokers? Hey, yes, they are former smokers. Do they have any other lesions? Let's say we don't know. Let's just say we say no, because let's say we don't know. But you can ask yourself, okay, where's the location? Lung cancer tends to love the upper lobe. Okay, anybody who's treated patients with lung cancer, you realize that a lot of them show up in the upper lobe. So is that cancer located in the upper lobe? Say yes. Is a noodle speculation? For our radiologists, they know what a speculated noodle is. On CT, it's very clear what a speculated nodule is. Just using this simple calculator, you can see that nodule that you found on CT, on X-ray, it's an 87% chance that it's a cancer. Now, below 60%, you probably cannot hang your hat on. What if that nodule was, say, let's just go to 40. Now, what? I'm at 97.8% chance that that's a cancer. So again, this is a tool that we can use right now. Again, for you people doctors in Cameroon who are interested, you can obviously go online, you can call me, I can try to put you in touch with other doctors that have used it. There is a tool that is available right now. I'm going to go back and return to my slides. So this is for initial screening. Now you know that, hey, this guy is a high likelihood that he has a cancer. When a radiologist is presented with a patient comes in to get the CT scan done or your X-ray done, the radiologist has two options, right? They can either just describe what they see on the CT or on the X-ray, or they can perform some kind of an inference, right? An informed diagnostic conclusion. But they have to know the patient's history, or they have previous scans, right? Very often they don't have that. Very often that the private doctor knows that patient better. So this information that even the private doctor can use and say, okay, oh, by the way, yes, this guy, he had been complaining of these symptoms in the past, and oh, he did an X-ray a year ago, and that nodule was only 1 cm. So now you can now see how you can now draw a conclusion that that is indeed cancer. Okay, just a second. Let me go back to my slide. Let's go back. All right. So that is the Mayo Clinic calculator that we can all use right now. All right. Next slide. So another question somebody asked me that, hey, why do I need to know? If I'm not going to do nothing about it, the patient cannot be treated, which is a valid question. Why do I need to know? Knowledge is power, right? It's very important that even if, just because you cannot intervene doesn't mean you shouldn't know. You'll be surprised how often you can act when you have information, right? When people know, then you can do a cancer registry, and then now you can identify high-risk individuals, right? We have limited resources. It's important to know the incidence of any disease in a community. So it's important, even if you cannot act, that information is valuable. And you can use that information to give to the Clinton Global Foundation, to other national organizations that can actually provide funding. That information can be used right now, and that's how we bridge that care gap. Because remember, this information, you might not find it handy today, but is going to guarantee to be used tomorrow. In today's world, data is everything. So we still should do our best to collect that data, even if we cannot use them right now, even if that patient cannot afford the treatment that cannot afford surgery or radiation therapy or basic chemo. That information is still important that we get. So the Mayo Clinic calculator, it works. It's been validated over and over and over and over. Again, you need to at least talk to a doctor who has used it, and they'll train you. It's not hard. So at least now that we know that thing is very likely lung cancer, right? We talked about the PET scan that is not available. We talked about the bone scan that is not available. Guess what? You can do a contrast CT of the chest and abdomen, including the liver and the adrenals. If you do that, then you can now start staging that cancer. You can know if it's a stage 2, stage 3, if it's or stage 4. If you start seeing stuff in the liver or the adrenals or the kidneys, then you start being concerned. Then you can say, well, the cancer has spread, so my intent cannot be curative. But if the cancer hasn't spread, then you can now say I have a curative intent. So lung cancer in Cameroon. So of course, surgery can be done for resection of early disease if it's caught early. But now we are lucky to have a radiotherapy clinic in Cameroon, in Douala, that is actually doing some work. I'm not affiliated with them in any shape or form, but I'm so proud of the work that they are doing out there. And as the physicians, please educate yourself on what they are offering in Douala. That way you can now educate your patients. Chemotherapy, of course, there's some centers that offer chemotherapy, and then concurrent chemoradiation. Those are the options for people who have lung cancer. But again, radiotherapy is now available in Douala. So here's my message to you, to my Cameroonian doctors. Right? Give me a second. Let me go ahead and... So here's my message to my Cameroonian doctors. Educate yourself on these services that are available in Douala. Educate yourself on the surgical centers that are available in Cameroon and in Yaoundé and the rest of the country. That way you can educate your patients. This is something you can do right now. You have to educate yourself. In the USA, you cannot maintain your license if you're not doing continuing education. Educate yourself. Because the last thing you want to do is to have a patient come in and then you start talking stuff that you're just because you don't know what you haven't done your research. Or you have a patient, because they are not well educated, they start telling you what to do. So you can educate. You're not trying to do it yourself, but you're telling them of places that have that option available. Let's be happy for what is being done in Cameroon right now at the Oncology Center in Cameroon. This is something for me that is very particular to me. This is for my colleagues in the diaspora. This is something that can be done right now to bridge that care gap. For cancer management, my diaspora doctors, find a young doctor in Cameroon and start a preceptor model. This is very important. Every little bit matters. One person can make a difference. I know people in Cameroon right now who are doing that. People in Cameroon people in the USA, doctors in the USA, whether they are cardiologists or they are urologists or they are oncologists. I know people in the USA right now who have found a doctor in Cameroon and they are working with them one-on-one in order to help bridge that care gap. The most famous doctors in the world, they did not get the knowledge from medical school. They learned in medical school, but the knowledge they got was through mentoring from other well-known professionals. Okay, I cannot emphasize this long enough. Get a mentor. In this town hall, it's a perfect environment where you can find other professionals in Cameroon and talk to them so that they can link you up with mentors. And you have to be committed, right? Pick somebody, a young person, preferably, who just got out of school and train them for a year. And you guys talk once or twice a week. That will make a big difference to bridge that care gap in Cameroon. Again, most solitary cancers will not kill you, okay? Early diagnosis is everything. Remember, metastatic disease is what kills you. That's why we dial down. That's why we double down. People usually, here's a statement that most of you don't know. People don't hear, most cancers, like breast cancer. Breast cancer by itself will not kill most, very few people die from breast cancer. What kills is metastatic breast cancer, right? So if you know that, why don't you do everything to diagnose that patient early? Cancer is never an emergency. Cancer kills you by overwhelming your body. So it's very important that we catch it early. And that is what you do when you're talking to your patient when they come in for any other condition. Never an emergency. A blood clot and an aneurysm will kill you right away. Cancer will not. Cancer will never kill you right away. So that's the good news, but we have to diagnose it early. So another thing that we can do right now, these recommendations, the recommendations I'm giving are not things that where I conjured up. There are organizations out there that are providing guidelines. So this is the Breast Health Global Initiative. They would go out there and give you recommendations on how to manage breast cancer in a low resource setting. They are aware that we don't have the PET scans, the MRIs, but that information is out there. We can go out and read it and equip ourselves so that we can better handle these patients. So the most common cancers in Africa are called breast, cervical, colorectal, and prostate cancer. So question, which of these cancers has a higher survival? It's breast cancer, right? Breast cancer has a 99% survival if caught early. We need to dial that in. Keep telling our patients, breast cancer is curable. If it's diagnosed early, you can get cured. You have a 99% chance of surviving. And that is why screening is probably the most important thing that we can do in Cameroon right now. That 5-year survival is 99%. Here is a slide from the Breast Health Global Initiative. Notice what they say. Heightened breast healthcare awareness in our community is super important. They use that word heightened on purpose. We're not just talking about screening or awareness every once a month or on World Cancer Day or World Breast Cancer Day. The Breast Health Global Initiative says heightened breast health awareness would make a difference. Demonstration projects have shown it. So we have to double down on breast cancer awareness. Everybody, we have to be on the same page. We're all talking about it. We're all telling people that it's curable. And what can you do right now? Steps that everybody in this town hall can do right now. Sponsor or participate in an awareness event. Spread the word. Educate your grandmas and grandpas or your aunties and uncles and brothers and sisters. Breast cancer is one of the most curable cancers. That is the good news, but we have to do something. Of course, I'm not going to talk about diet, exercise, and those things are those are the easy ones, right? The low-hanging fruits. They are very important, super important. We all know that, so I don't have to reemphasize that. So, breast cancer prevention and screening. Unfortunately, breast cancer is hard to prevent, right? So yes, you can exercise, you can good diet, good lifestyle. Yes, that all that helps. But screening is probably our only choice. So we need to double down on screening. And screening in Cameroon can be done. Clinical physical exam. When I went to RAD8 conference, which has professionals from all over the world, low-cost countries. I spoke to quite a few clinicians there, and they all said the same thing. Clinical exam is the best tool that they have at their disposal. Mammography, I'm not going to talk about mammography because that is a problem, okay? We don't have enough mammographies, but we cannot fold our arms and say we can do nothing, all right? Things are being done in Cameroon to try to fix that problem, but that clinical exam, every practitioner in Cameroon should know how to do a clinical exam. You're helping your constituents. Learn it, it's easy. It's really, really easy. I want to acknowledge one of our town hall members, Akpi Anjo, who's doing a great job with breast cancer screening in Cameroon. It makes a big difference. It makes a big difference. So that's something you can do right now. So of course, like we talked about the TNM stages for breast cancer, where the T is for the tumor size, the lymph node involvement, and the M is for if it's metastatic. How do you get the T stage? Well, the tumor size, you can get it on ultrasound. You can get it on CT scan. That is available right now. That can be done. Lymph nodes, of course, there's no PET scans, but lymph nodes or ultrasounds can catch those lymph nodes. So it's available right now. Ultrasounds are not only for OB and cyst and bowel obstruction or other abdominal ailments. Ultrasounds would catch lymph nodes that are swollen, that are cancerous. Clinical exam, palpation, can catch lymph nodes. CT scan with contrast would catch lymph nodes. Distant metastasis, CT scan with contrast, chest and abdomen, would catch it. These are things that we can do right now. Again, let us not sit and fold our arms and say, oh, we don't have MRIs. Yes, we don't have them. We're not going to have them anytime soon. Only there are a few of them that exist, and only a few people have access to them. Access to healthcare is never going to be equal. In the US, when COVID hit us, guess what? the president and the governors, they all had access to monoclonal antibodies. They had access to treatments that you and I, who are medical professionals, did not have access to. So we know that some people are going to get MRIs in Cameroon, some people are not, but we cannot fold our arms. Those are things that we can do right now. So we've diagnosed the cancer. What can we do about it for breast cancer? All right. Of course, there's surgery that can be done. Here's a very interesting. Let's go back. This is the slide I'm looking for. Right, I'll come back to that slide. So of course, there's surgery and there's chemo, and there's hormonal and there's radiation therapy. Surgery is doable in Cameroon. I found a very interesting study that I'm going to share that shows how much surgical expertise is present in Cameroon, and I'm very proud of that. I'm very happy. Nobody can convince me and tell me that in Cameroon we cannot do a lumpectomy and do it well. Obviously, mastectomies are a lot more complex, but there's a study that I found that said surgical intervention in Cameroon is the #1 intervention. And it makes sense, right? Because that's something that we can offer our patients. Chemo, hormonal, radiation therapy are not widespread. So for all these 4 options, only surgery is what I'm going to talk about. And then, of course, I'll talk about radiation therapy. I will not talk about chemo. I'm not going to talk about hormonal therapy. So lumpectomy versus, so let's talk about surgery. Lumpectomy versus mastectomy. I'll argue that it's easier to convince an African woman to get treated if we can offer them breast conservation. Once you talk about mastectomy, because of the socio-cultural impact, that patient is going to walk away from your office and they're never going to come back, right? If we can offer lumpectomy, then they can start thinking about it. But like we know, you cannot offer lumpectomy without radiation therapy. And I have some slides some things that are happening right now that are very, very exciting. But let us understand that in America, mastectomies they are done, and women have there's more body positivity in America, not the same in Cameroon. So if anything, we should be able to convince the world that the lumpectomies are more would make an impact on cancer care for women than mastectomies, just because of that social cultural aspects. And also mastectomy is a harder surgical procedure, right? So that's obvious. That's something that you need a lot more expertise. Whereas a lumpectomy with the right training, a good general surgeon should be able to do a decent lumpectomy with wide margins. So there was our guy back then. He was still skeptical, and he's still very skeptical right now. If you talk to them about something that they don't know, you haven't given them more information about. So a patient comes in and you're able to diagnose them. They have breast cancer. You go in there and then you're able to do a lumpectomy. So what's next? Obviously, lumpectomy, you need radiation. You need radiation therapy. The great news, again, like I said, is a lot of countries. Cameroon has to. This was a study that showed that 100% of there was almost 100% management for breast cancer was surgical, right? And that doesn't mean that there's no chemo, there's no hormonal therapy, but that means that surgery has a good presence in Cameroon, and that's something for us to celebrate. But of course, when you go in and you do a lumpectomy, you need radiation therapy. Cameroon Oncology centers can do radiation therapy right now, but they are one clinic out of they cannot treat everybody, right? Breast cancer is very personal to people. If you can offer them surgery and radiation therapy, they will come. Women want to protect their breasts. Men want to protect women's breasts. We're all on the same team here. So radiation therapy with the linear accelerator, which is present in Douala right now. And what other options do we have, right? There is something called brachytherapy. That is not available in Cameroon, so we're not going to talk about it. But there's something called IORT, something that gets me pretty excited. IORT is intraoperative radiation therapy. What is that? When you go in, the surgeon goes in and removes that lumpectomy, that lump, that's a lumpectomy. You can do radiation therapy on the spot. The IORT machine from Germany called ZS Intrabeam. It is very affordable and it's available right now. I've done my research. I know what it costs. I'm not going to mention the cost here, but this gets me super excited. It's a lot less expensive than the linac that they have in Douala, but obviously it cannot treat, for example, it's not going to treat a lung cancer. But breast cancer, this machine is a game changer. 90% of breast cancers reoccur around the lumpectomy cavity, right? So when you go in there, you can now irradiate the patient sur place. That's the only French word I know. On the spot, you can irradiate them, and then we know that lumpectomy plus radiation is equivalent to mastectomy. Now we have women listening to us because we are not scaring them that they're going to get mastectomies. It's a single treatment. It's done at time of surgery, so it's convenient, and the patient are compliant. Radiation therapy, they have to come 28 times or even 42 times for prostate cancer every day. Not many people, even the USA, even right now, we have patients who are not compliant. They will come Monday through Friday, and then they'll leave for a week, and they won't come back. That cannot work. With IORT, that surgery can be done right on the spot, and it is very effective. It's less costly, like I said, to acquire and to maintain, but more importantly, the radiation safety is a lot easier because it uses very low energy 50 kV photons to deliver that dose for 10, 15, up to 20 minutes, or sometimes even longer than that. And then you can irradiate that tumor bed. It is safe, it is effective, it's got better cosmetic outcome, and you can treat a lot more women. So IORT intraoperative for me is a game changer because it's available right now. It's available. And there's lots of studies that have shown, like this study from the UK, Australia, and I think there's one of the authors is from the US, showing that global adoption of IORT is better for patients. It's better for healthcare systems. That's one study. There's another study showing that it's better. There's another study. There are lots of studies. And if you notice it, a lot of these studies are all in the past 4 years. Okay, this is 2021, this is 2022, this is 2020. They're all in the last 3 years. So they are recent. These are recent things that are happening right now. It is affordable. This town hall, if all the medical professionals in this town hall, we came together and started a meeting, we could come up with a plan to implement IORT in Cameroon. We have the physicists, we have the oncologists, we have the radiologists, we have the breast surgeons. It's doable. Again, like I said, it's a single dose, and so it's getting ground around the world. South Africa, they installed the first unit in 2018. It's the only one in Africa. The picture on the right, those are the little applicators that are used when the surgeon goes in there. They take out the tumor, white margins, of course. That's a discussion for another day about pathology for margins. But if you can get a white margin, you're still better off than that patient not showing up at all. And then you can irradiate them and single dose of radiation, and the patient can now walk away knowing that they are getting almost the best care that they can get, even in America or in Germany or in France. So there's no reason. South Africa has it. There's no reason why Cameroon cannot get it. Like I said, within this town hall, we have enough professionals that can pull this off because it is not as complex as the linear accelerator, which again, I'm so proud of the work that I do in Douala. When I started here at my hospital, the hospital was going to donate a linear accelerator to Cameroon. I tried my best to offer that linear accelerator to a church in Cameroon. But obviously, the manpower, the expertise, the money, and the maintenance the cost is overwhelming. So let us support the people in Cameroon, the oncologists in Cameroon that are doing this. Let's do our best to support them. This is easier. It's not a walk in the park, but it's easier to implement in Cameroon. And that's something that we can do right now to bridge that care gap. So like I said, can IORT be done in Cameroon today? My answer is a big yes. So these are the places in the world that has IORT right now. You can see there's one dot in South Africa, none in Cameroon. But because I am a single individual, and I think right now I'm in my office by myself, I can tell you that I'm going to put a dot and say Cameroon is next. We can do it. This gets me very, very excited. So hopefully I've been able to share a few things to this town hall today on how we can do to bridge that care gap and actually make a difference in cancer care in Cameroon. Thank you.
Wow, that is thrilling. You said thank you when I'm still holding my pen ready to take more notes. Can you continue? It's not enough. We want to hear more. Thank you very much. Sidney, this has really been exciting, and I'm sure everyone in the town hall will agree with me that it's really been a wonderful presentation. You can stop sharing your screen just so we can have some interaction. This is really, really great. I'm sure a keen listener like Brian will first have the first comment. Brian?
Yeah, I think it was great, and you can see Elvis from the reaction from the chat. I think Dr. Bernard posted a lot of very critical questions in the chat, and I think it was really, really very exciting talk. I was hoping to hear more about cyber knife as well, and that's been yeah, because it's been recently, I think in the last in the last few weeks, there's been an increased conversations around the use of open AI and how that's revolutionizing, the tech space and things like that. So I've really been very curious about the use and how, if that's going to take away your job and make you jobless in the next few years. So things like that have been really rising. But I just wanted to, I do see that Dr. Foyong is also in the chat, and I know he's a neuroradiologist. I was wondering, Dr. Foyong, I don't mean to put you on the spot, but I was wondering what your thoughts are really on the increase. He talked about the increased incidence of cancer in Cameroon and in Africa, and I was wondering what your experience in this field has been, and if there are any contributions you have, Dr. Foyong.
All right, thank you so much for giving me the chance. And I just wanted to say thanks, Sidney, for this presentation. I think it's a really, really nice presentation, and he really broke down cancer care in Cameroon in a very simple way that we could all get. I do agree with him that cancer is becoming an increasing problem in Cameroon. He stated some reasons as to why that is becoming an issue. We're beginning to live longer, so we're seeing more diseases that come with age. Obviously, our lifestyle is changing, and then there's always the genetic factors that come into play. Exposure to certain things in the environment also come into play. But yeah, we're beginning to see more and more diseases. I'd say that there's a little bit of a confirmation bias as when it comes to just diagnosis of cancer overall. Some of the reasons why we see more cancers is because we now begin to check for more cancers. We have better tools to check for them, and we're becoming a little bit more aware. But I'll tell you that there were probably a lot of missed cases in the past. So it's some of the reasons for for us diagnosing or seeing more cancer may just be because we're looking for it now more and more. But overall, I think that that's becoming an increasing issue. So we should also, obviously, just like Sidney said, we should, we look at our other diseases, but we should also put some attention on looking at cancers in our patient. He mentioned two things in particular that are really that we can begin to do and do well. He mentioned prevention and early diagnosis, and I think that will almost be the cornerstone of our cancer care for now. Because we can work a lot on prevention and control a lot of things on that end. And then, early diagnosis obviously is important. I know we have an issue with late stage diagnosis in Cameroon, especially for something like breast cancer. I know we see a lot of stage 3 and 4 cancers, which in most cases, are really difficult to work with. But if we can get them early, we can offer some kind of treatment for these diseases. So, overall, I would say, I'm really impressed by what Sidney presented, and I'm more impressed with the work he's doing in Cameroon. And I just want to applaud him for all the good work.
Yeah, thank you so much, Dr. Foyong, for your really, really nice comments. And we're just taking some few comments to give Sidney some time to sip a glass of water before we start the question and answer session. And Dr. Yaoba is in the hall. Yaoba, some comments from you about the presentation?
Thank you very much, Elvis, and thank you very much.
Before you continue, he's appearing as Elvis Ndasi because I sent him my link. That is Dr. Yaoba Seidu.
In short, yes, Dr. Yaoba Seidu, you're big for over 7 years, right?
Yes.
So, okay, thank you very much, Elvis, and thank you very much, Sidney. I think that was really, really an exciting presentation. And it's kind of really interesting and inspiring to see the degree of technological innovations that have occurred particularly in the therapeutic aspect of cancer, notably the radiology side. So as Elvis mentioned, I think cancer is really like a very big problem in Cameroon. I think each year we have about 16,000 new cases of cancer. And then I think when we look at the top 3 cancers, I think we tend to see that breast cancer is like the leading cause of cancer in Cameroon, followed by I think cervical cancer and then maybe prostate cancer. So the other ones, their prevalence seems to be somehow low, but not negligible. And then you did also mention the issue about burden of cancer, which is really, really significant. And then we also have, in short, we are also beginning to see an increasing number of cancer in children, particularly things like cancers like lymphomas and so on and so forth. But again, the underlying challenges are the same and they are kind of perennial. And I think we have done a number of studies. We have submitted like 2 articles of publication on the state of cancer and state of cancer, as well as the services for cancer care and treatment in Cameroon, focusing on both adult and pediatric cancer. So in short, the challenges, as you mentioned, they are very, very clear in our context. So late diagnosis is really, really a problem. I think almost 80-90% of the cases, they are diagnosed late for a number of reasons. One, I think there are issues related to capacity of the healthcare providers. Most often diagnoses are missed at the lower levels, particularly at health centers, even district hospitals, and also regional hospitals, which is really a capacity issue. And as Mono mentioned, there is just really no guidelines that can guide clinicians on how to diagnose cancer. So that's really like one of the big problems. And then the second issue, aside capacity, is that of the technical, is like the technical capacity or platform, as they call it, the equipment that we definitely would need to like either diagnose cancer or for diagnosis, things like X-ray and all the other things that you have cited, like biopsy and so on. So these are services that are really, really not available, particularly within the primary healthcare system and even up to the district and also regional level. So which also creates another layer of complexity. And then there are also cultural aspects like some social science aspects like maybe beliefs, myths, and so on and so forth that always tend to like maybe direct the patients towards maybe a traditional practitioner, or a pastor. And all of those factors also affect the timeliness of diagnosis, which again can have an impact on the outcome of the cancer, which ultimately will contribute to increased mortality. So in Cameroon, I think really the figures we have kind of indicate that cancer is like the #1 cause of medical evacuation in Cameroon, be it for any type, particularly for most of the civil servants, people work within the government, and it actually costs a lot of, hundreds of millions to actually evacuate people to France, US, or India for treatment. And this is like money that can be kind of tailored towards this type of investment, investing in new generation equipment, building capacity, so that at least the country can actually have like the technical capacity to treat patients rather than sending them abroad. And I really applaud the initiative that Dr. Morbid and his group, as well as you guys are doing to actually address the issue. So I think apart from the radiotherapy center in Douala, there is just no functional radiotherapy service in Yaoundé. I think most of the times we did have radiotherapy machines in Douala and Yaoundé, but today none of them is functional for a number of reasons: lack of technicians to maintain the equipment, lack of spare parts, and also poor quality of power and so on. So the challenges are really real, and I think we really need to like step out from all of this theoretical aspect. We do understand the challenges, and then see how we can really like canvas all what we know to develop practical solutions on how to solve these problems. And I'm really pleased to see that you guys are making important leeways on developing plans that could actually enable us solve some of these perennial problems. At CHAI, I think one of our core focus is really how to improve access to affordable and quality cancer medications in Cameroon. Because if you go to the 7 treatment centers in Cameroon, you will not see sufficient. What you will be sure to find is stock out of the basic anti-cancer medications. So then they're ranging from things like the medications like methotrexate and so on and so forth. So there is that problem. So even if patients have the money to pay for these drugs are not available. They can only be accessed in pharmacies in Douala or Yaoundé, or at times imported, which can actually like inflict a very huge financial burden on the family. So at the level of cancer of the Clinton Health Access Initiative, we are working with the Ministry of Public Health to actually establish a system that we put in place in Nigeria, what we call chemotherapy access partnership. So we have partnered with the American Cancer Society and then signed conventions with 5 pharmaceutical companies who have accepted to provide medication at 50% the cost of the medication, so at factory price. And I think we have this convention for about 38 molecules. And I think in the next couple of weeks, we'll be working with the Ministry of Public Health to see how this system can be deployed. We know that there is going to be a lot of challenges, but we are really confident that with the commitment that we see coming from the leadership of the Ministry of Public Health, we will be able to like roll out the system and ensure that the anti-cancer medications are readily available in all the 7 treatment centers. So over to you, and thank you again, and courage with the work you are doing. Over.
Yeah, thank you very much, Dr. Yauba. Thank you for the work you're doing as well in Cameroon, and I'm sure a kind of collaboration with Sidney and Yauba, you can imagine the impact we can have in Cameroon. And I know a lot of questions are getting set to be asked to Sidney. We're still going to have about 50 minutes more of conversation and interaction. So be sure that you're going to have your question answered. And just to remind you, ladies and gentlemen, this program is being streamed live on Facebook. And after, we always also download and host it on our YouTube channel, where thousands of people always come back to it to watch, for those who are not opportune to tune online. So at this point in time, I know we have people who are also, one of the things that caught my attention in the presentation is the fact that Sidney keeps saying, what can we do? What can we do? If you cannot sponsor an event, you can participate in one. And we have one of our town hall members, Dr. Samuel Ndijeka, who is also one of those people who believe in doing something and just doing something back home. And of course, Dr. Samuel, what are your thoughts about what we can do, even at individual level, to improve the situation of what Sidney just presented? Any comments on this presentation? A few minutes.
Thank you very much for giving me the opportunity. And Sidney, I want to thank you and applaud you for the work that you are doing also. You just mentioned one thing. You said you are going to do everything to get what you want to get to Cameroon. At some point, the challenge I have, I work at the University Southwestern Medical Center in cardiology, congenital, but I'm more involved in global health, not even in my field. I just wanted to say, when I met with the Prime Minister, His Excellency Philemon Yang, the one word that I told him was, I said, Your Excellency, you will not make it to France if you were to have a cardiac arrest. And I saw one of our colleagues here talking about evacuation, that evacuation is always late. So my comment is that it is us here that will bring that change. And it's when you start little by little, one step at a time. I just wanted to add that what we are doing in Cameroon right now, even though we cannot offer everything, is we talk about screening. I have a foundation, Faith Gardens Medical Foundation. I'm working with a group based in Sweden. It's called Spider Network Center. You go to spidercenter.org. You're going to see what they are trying to do is also in the same line. They've just launched a program called Digital African Network for Cervical Cancer Elimination. And that's part of what Professor Ngwa that you mentioned. He's been really at the forefront from doing a lot of things. And one of the things that we can do here to add to help is replication. The town hall is giving us an opportunity to know what A is doing, what B is doing, so that we don't waste resources doing the same thing over and over, which are the I want to say artificial intelligence is helping. What we are doing on our part is I have a doctor, her name is Dr. Duanla, and I have a retired gynecologist and obstetrician trained in colposcopy. He is based in Sweden. What he does, I had to make all this negotiation. He gets up every Saturday morning. Dr. Duanla has a mobile colposcope in Cameroon, and Dr. Philip has taught Dr. Duanla on how to do screening using this mobile colposcope. The information is then loaded into their system in Sweden, and he can then analyze the images, which is another way of making use of artificial intelligence. But now when we do diagnose this cervical cancer, what is the next step? That is where Douala and Yaoundé comes in. The surgical part of it, which is the hysterectomy, is working very well. The radiation part that Sidney talked about is not, the chemotherapy, of course, is not even really well established. So the challenges are there, but if we take it one step at a time and at least doing something on the ground, that will be very helpful. It does not matter. He mentioned one thing. If you just become a mentor to one clinician or to one provider back home, we have like a model for cervical cancer, for breast cancer screening, which we took to NDOP, and just having these doctors to actually even learn how to do an exam. You will be surprised that there are little things we can offer from this side that will be very helpful to make a change. We have to start from somewhere. Sorry that I'm taking a lot of time. Thank you very much.
Thank you. It's always a pleasure to have you, and I'm sure you all agree with me that the work you are doing in DOP is amazing, and all your connection. I mean, it's amazing. You always so interested in global health, far from your day-to-day job, but then the impact can be felt. Thanks so much. And I'll hand the opportunity to our chair, Dr. Muno, for your comments before we now, Brian, you take it away from me for the question and answer. Hello, Dr. Muno.
Oh, thank you, Elvis. I am super excited with the presentation. It was a very practical presentation. I personally did learn a lot. Sorry for looking at my phone right now. I'm having some text coming in. So it's one of those things, as Sidney said, let the perfect, I try to write it down, not prevent us from, or not hinder us from doing the good. And it's something I really need to learn from this, because we're not going to get into perfection. I could tell you the wonderful things Sidney does. He didn't even mention radiosurgery, things that he does. He knows it's not practical in Cameroon at the moment. So he was directing this discussion towards things that we can really do so that we stop complaining and try to make good use of the resources that we have. I'm a medical oncologist. We are doing wonderful things I cannot start describing to you. It can be lectures for only lung cancer. We can talk about it for a month. I think so. Just the number of innovations we do in lung cancer, we can talk about it for a month. I mean, 3 hours lectures for a month. We can do that. But he offered practical solutions, and I think we're going to use that as a basis, Elvis, to see how we can all influence cancer care in Cameroon. As we all know, prevention is better than cure. So let's start with how can we prevent these cancers in the first place? How can we screen and diagnose them early? I'm one of those who have been, I know Anjong is not here, but unfortunately, we've been having a lot of cases at times, patients refer to me, or I'm being involved in the care of ladies, young girls who are having inappropriate treatment and getting cancer diagnosed very late. And it feels sad to see our mothers, our daughters, our sisters getting this kind of suboptimal treatment where there are certain things that we could really do in order to help, and simple things. So I want to thank Sidney for leading this conversation. I learned a lot, and I think we're going to have a good time discussing. So thank you very much.
Thank you, Mono. And I would hand over to Brian to moderate the question and answer session. And of course, with Christelle, Christelle is available.
Yeah, thanks, Elvis, and thanks again, Dr. Sidney Tazeh, for your presentation. I think that if you have any questions or any comments, please feel free to drop them in the Q&A box or in the chat, and then I can call you up from there. Otherwise, you could also raise your hand, and we will call you on to make some comments. But Dr. Tazeh, I wanted to start us off with a kind of interesting question that Dr. Sabena asked in the chat, and he was asking a question about the incidence of cancer. And he said cancer research and cancer screening has obviously increased in the last few years, and this could explain the increased incidence. But does it mean that the incidence, does that mean the true burden of cancer has increased over the years? So I just want to ask you that, and what sorts of studies do you think would be, I mean, what are some ways in which we could measure the true burden? I think that's some sort of what Dr. Sabena was alluding to. What sort of studies would be needed to measure the true burden of cancer in our population?
Yeah, so a couple of, when I think of burden for cancer, the number one thing is like in the US is loss of income and suffering, right? We know that Dr. Muno mentioned quite a few young adult females who passed away sadly because the cancers were diagnosed. Some of them actually were diagnosed early, but because of poor management, they ended up losing their lives. So death is obviously one of the biggest burden. And then of course, when they died, the income is lost. Now the kids are not able to go to school, and collecting the data for the people who are suffering from this scourge, people who are either dying or who are dead, is going to be the only way that we are going to be able to now say, yes, this is information that we can use to ask for resources. All the studies that I've looked at, unfortunately, most of them talk about Nigeria, Ghana, South Africa. Very few come from Cameroon. Very few come from Cameroon. So that is why those doctors visit. As far as direct answer to your question, how do we start collecting that data? That data starts at the level of the hospitals, the doctors, and when they go see the patients. Very few clinics in Cameroon have cancer registries. Very few. I don't know if they even have. So how do you, so you got to start somewhere. You got to start somewhere, and the best place to start is educating the personal physicians, the internal medicine physicians in Cameroon, to start talking to the patients about it, and then that's how that information gets fed into. I don't know what organizations in Cameroon that are already set up right now to now start compiling all that information, and then now we can say, hey, yes. Here's data to prove, or here's data, because we know people are suffering, but you need to be able to show. Nobody's going to give you a penny if you cannot show it. So that cancer registry is how you start collecting that data.
Yeah, thanks. And I'm really glad that you mentioned this. I think we definitely need to increase our surveillance mechanisms for cancer, and definitely that starts at the most peripheral level. If we don't have data, it's very difficult for us to do any sorts of epidemiological, studies, to infer, to even answer some of these questions that Dr. Bernard raised, which I think are very critical. I want to think on.
So, yeah, just to add to Bernard's question, there are certain cancers that we're picking early. That's true, because we're screening early, and we may not be having any impact on survivorship over time. Data has shown that. But there are other cancers that we're actually having resurgence. What led to Doll and Hill publishing in 1950 about smoking and lung cancer was an observation everyone saw in London. There were more lung cancers, but nobody thought smoking was the cause. They analyzed the national data in England, and what they realized, smoking was the last thing in their list. I think those who have done public health will know that that's the peak of how retrospective studies started. And in their analysis, finally, they found unbelievably that the correlation between smoking and lung cancer was super high. And their data was debunked by most people in science for 10 years before this became, and we know right now that this is what is happening. So there are things we do. We don't know the effect of illegalizing marijuana in the US. We don't know what it's going to do with smoking. Nobody knows right now. In the future, we may start seeing things. There are surgeons who are seeing that putting patients on anesthesia right now in most places in New York City is more difficult. We need more anesthetic drugs. Those are observations. Everything starts with an observation. So there are other things that you would see that because we started screening prostate cancer early, we got more diagnosis of prostate cancer. Then when the US task force decided to stop screening for prostate cancer, the incidence dropped, but mortality increased. So you get to see consequences of things we do. So epidemiological, Bernard is a public health specialist, I know that. So he's asking a lot of technical questions here, but these questions, there are some of these cancers that actually the prevalence is increasing. There is data in the Western world showing that. There is data showing that some of them are stable, and there is data showing that we are just improving our technologies to pick them up earlier. And if God knows we can cure them, as Sidney said, we are curing 99% of breast cancers in the US because we are not just diagnosing women. We are actually screening them, catching them in stage 1 and stage 2 and curing them with all the brilliant methods that he talked about. Most of the time, we come in fancy as medical oncologists just to give some 1 or 2 things that may change life expectancy by 1%, 2%, but we are not the ones doing the bulk of the job.
Absolutely, absolutely, yeah. Our way out of cancer in West Africa and Africa is through screening and early diagnosis. Okay, we are not going to drug our way out of it. We're not going to chemo our way out of it. We're not going to radiation therapy our way out of it because it's going to take a while for some of this. Here in the US, sometimes my cybernet goes down. It goes down for 4 or 5 days. Okay, and we have all the experts here in the US to be able to come and QA and fix and QA. Now, imagine having that same machine in Cameroon. It's going to be down for 3 months. Then it's not sustainable anymore. So we have to double down on awareness and early diagnosis, and then that surgery. I'm so happy about the penetration of surgical intervention in Cameroon. I think that is our ticket: early diagnose, surgical intervention.
Yeah, awesome. Yeah, Dr. Marek, I'm curious about your experience on the sorts of surveillance systems that you have and what sorts of practical ways in which that sort of system can be built in Cameroon. Someone made a comment in the chat that there is a cancer registry in Cameroon, but hasn't been very functional due to, someone mentioned, funding. So just wondering what sorts of surveillance mechanisms you have in place in your practice, and what sorts of translational surveillance mechanisms could be implemented in Cameroon. What do you see, and how could that be useful?
So as Sidney already made allusion to, in the US here, we do have surveillance system cancer registries in all cancer centers, all hospitals. We have dead reports where we're able to survey even those who are coming in. We have registries that are registered nationally. When patients come in, these data are sent to CMS. So we can get data from initial admissions of patients and diagnosis. We can get data from number of people dying because it's electronic records that are kept in place. Cancer centers do have registry for different cancers, what stage and what kind of treatment they are getting. Then other thing which I would want to talk about, every cancer, like let's say lung cancer, there is a screening program for lung cancer. I'm not even going to go to breast, where anyone who had smoked greater than 20 pack years, it used to be 30 pack years cigarettes, at the age of 50 going forward, gets a low density CT scan screening. All centers and all hospitals that do that do have a registry for the nodules that they find. And as Sidney showed you, the Mayo, there's a lot of wonderful technology that we can actually use just with CT scans without doing PET scans, and classify and be able to biopsy some of those nodules and tell us. And there are registries too for that. For individual cancers, there are registries for screenings. There are national guidelines for, let's say, cervical cancer, all cancers that are related to HPV cancers. You know, just by vaccinating ladies, our young girls and boys at 11, we're going to prevent head and neck cancer, throat cancer, penile cancer, anal cancer, cervical cancer, not only cervical cancer. Australia is almost at the point of elimination of cervical cancer. You can imagine that what that means. It used to be the #1 killer of gynecological cancers in the US, now is #3. It's gone to the last. Everybody has come ahead of it. Those are things that can show you. And in Cameroon, it's #1 gynecological, and even among the first 3 or 4 highest killers. So you get to see that there are things that we can do. There are registries. Registries doesn't really mean that it should only be found in the cancer center. Even at level of district hospitals, people should be able to pick up those lumps that they are suspecting and document them and send them to the national level. So I think Sidney may have more to add.
Yeah, absolutely, absolutely. That's where it has to start, because this early diagnosis the first person that the patient sees when they have a concern is your personal doctor, right? Yeah, so we're not here to rely on the big centers. The big centers are the ones who process that data. So it starts with educating the local physicians that when you see these cases, document them and aggregate it over time. And then we can process all this data, and then now we start having an idea of the true incidence or the true burden. Because that's one question that somebody asked. That does that mean the true burden has increased over the last few years? Yes, it has increased. But we have to laser focus on the local providers who are seeing these patients day in, day out. They are the ones, that's where the difference is going to start.
And Brian, you know, we have minimum package of activities that go on at the level of the district. Okay, package minimum. I'm going back to Cameroon. Sir Bennett is a district medical officer. He can tell me how many of those things have registries for you to say the number of cervical cancer, breast cancer, lung cancer. They are not included. But you have other things are included, which are a priority for us. That's true. We have to tell the number of malaria cases. We have to tell the number of TB cases. We have to tell the number of diseases that we have never seen, even schistosomiasis that never exists in the Northwest. But you have to tell those things there. And but if we can include cancer, I think I've not been back in those meetings now for the past 11 years, but I think there was an effort to try to integrate it into it.
Yeah, thanks, Mono. And I think it's really understanding the drivers of this increased incidence of cancer is so important, even at a molecular level and a genetic level. I think there have been lots of studies around epigenetic changes as well, and how that's impacting the increase in the incidence of cancer as well. I think doing as much studies, understanding what's really driving this increased incidence of cancer, not only in Cameroon, in Africa and globally, is so crucial. And to do that efficiently, I think we really need to have a really rich database. That said, I really wanted to call on Dr. Antoine Bola. I really don't want to put you on the spot, but I know he's an ENT specialist at the CHU in Yaoundé, and also he's an, I think, associate professor at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé 1, and I know he treats a lot of cancers. So I don't know if Dr. Antoine, if you're willing, you can speak in French also, if you're willing to come in and make a few comments about what your experience has been treating cancers in the CHU hospital.
Thank you so much. I'll try to speak in English. I don't know if you can hear me now.
Yeah, we can hear you perfectly.
Yeah, for sure. I'm an ENT surgeon, and I've been trained in ENT cancer when I was doing my internship in France. So I've been dealing with a lot of ENT cancer, laryngeal cancer, throat cancers, and even what we have the most, which is nasopharyngeal cancer, which is really the first ENT cancer in Cameroon. The main problem or the main issue that we are having right now is the fact that patients do come late to the hospital because the diagnosis is not really made on time. They will move around, they will look for a lot of doctors, and unfortunately, the diagnosis will not be made at the right time. So when they come to the hospital, the main problem that they have is that they don't have money. And most of the time, most of those cancers can still be managed by surgery, unfortunately, except for nasopharyngeal cancer, which is, of course, a cancer which cannot be managed by surgery, only by radiation therapy and chemotherapy associated. So the main issue is the fact that they don't have money. So sometimes they can afford the surgery. So we propose the surgery. And at the end of the surgery, most of them will, of course, probably need radiation therapy and sometimes chemotherapy. And of course, most of them will not be able to go again for those therapies that could help them. And they will end up either we are going to lose them or they will not be able to make it and they will die. So one of the main issues is, for me, I think which something that could be done is to try to concentrate all the effort in maybe 2 big towns like Yaoundé and Douala, create centers that can, take care of all those patients. So some people in other regions can make the diagnosis at the right time, do the screening, and then send those patients to those centers that will be able to have the equipment and even the surgeon, the oncologist, and even the radiation therapists that will be able to manage those cancers. I'm sorry, I have a lot to say. I don't want to take a lot of time, but I think it's going to be good if we can at least have 2 or 3 major cancer centers in Cameroon that will be able to manage those patients, and also train physicians, especially general practitioner, family doctor, to be able to at least screen the patient, and whenever it's possible to send them to those centers so that those centers will be able to take care of them. And one last thing, I think we as a doctor, we are going to try our best, but also the state and the government, and of course the health system should also help us a lot in order to manage those patients, because the main issue with those patients is, first of all, the fact that they don't have money, and secondly, that they are not diagnosed at the right time. So sorry for being long, but I'm really impressed by what you guys are doing, and I was very happy to participate. Thank you.
Yeah, merci beaucoup, Prof, et merci beaucoup pour ton intervention. Really grateful. I think we're going to be reaching out to you. Would really love to hear more about surgery, your work treating nasopharyngeal surgeries in Cameroon, and some ways that the diaspora can possibly be helpful in terms of transfer of skills and things of that nature. So we will definitely reach out to you after this to learn more about this. And thanks a lot for this contribution that you've made.
Yeah.
I do see.
Brian, I just want to say one of my interests is cardiothoracic oncology and head and neck. So in case we can always collaborate with Dr. Bular in any time. One of my interests in oncology is that. So.
Yeah, and I see there was a comment there from Dr. Tambe saying that surgery is the most prevalent option in Cameroon, partly due to availability amongst the other treatment options, and that people don't know that there are other treatment options, and that's so true. And we know that surgery is still the gold standard for any cancer intervention. That's why even for radiosurgery, which is what I do, our goal is to have a result that mimics surgery. So when a patient has a 2 cm long lesion and I use a cyber knife to give them a very high dose over 3 fractions, that tumor after a few months is literally dead. We literally, quote unquote, burn it with radiation. So surgery is still the gold standard, and we should definitely double down on promoting the surgical subspecialties in Cameroon and encourage them. And obviously, the only way surgery becomes used more, has the biggest impact is on those patients that are diagnosed early. So it comes again back to early diagnosis, because again, we know of many people who go and have surgery and they already had stage 4 cancer, and then that surgery is just waste of money, waste of resources, and not the best intervention for that patient. So early diagnosis and surgery is our way out of cancer scourging in West Africa.
Yeah, thanks a lot, Sidney. Always a great intervention. I do see that Dr. Yauba's hand is up again. I don't know, Dr. Yauba. Then I'll call on
Yes, thank you very much. I just have an ask for you guys. I don't know how you guys can help and whether you guys have like the capacity to do so. So we are currently working with the Ministry of Public Health to construct a National Institute of Cancer. So it's like going to be like a center of excellence for the diagnosis and treatment of cancer. And it's also going to have like a research component, initially a research department, and also another department that is going to be involved in fabrication of basic anti-cancer molecules. So I think we have already secured funding from one donor, but the only challenge we have now is actually developing a business case, because the donor has asked us to develop a business case to actually clearly articulate, in short, what we want to do, the projected revenues, and so on and so forth, and how much it's gonna, in short, the duration of time that it will require for us to recoup the cost of investment, because the entire project is estimated at about 350 million euros. So we are currently stuck at the level of the business case. So I don't know whether you guys have some expertise that you can help us with to finalize this business case and submit to the donor. Over.
Yeah, I think that's a really great call for action. I don't know, Dr. Sidney, if you have comments on that. I've been reached out for other sort of related projects in Cameroon for a completely different field, and but I'm curious about your experience in developing these kinds of models for cancer. Particularly for this National Institute of Cancer that's being developed. Any thoughts, Dr. Sidney?
So, when I a few years ago, I met with Dr. He's in charge of Marfin Cancer Center. He's from Ghana, Yamoa, and he has done some really good work in Ghana, getting funding from NIH, getting funding from Clean Global Initiative. And one thing that he told me, when he mentioned, was you have to take him getting a lot of other Ghanaians for them to get the attention of the NIH. So this funding is, if that's the question is asking, to me, it's only going to come after we have started something, right? It's hard, yeah. We like what this town hall is doing, right? Is also step one. You have to have some professionals backed behind any project to be able to apply for grants or apply for funding. If you don't have names that are well known in the community and that showing how we're actually going to put those funds into use back home, nobody's going to give you those funds. Right now, RAD8 has an ultrasound, and that's a good example that I forgot to mention, an ultrasound training program where they have funds, they've got professionals who are willing to go to Africa and teach, and they've got the equipment, but they are just not going to give it nilly-willy, right? You have to show that you have the backing of experts, but for now to receive that funding. So the first part, we have to kick that ball. We have to take that first kick before those companies are going to come in and help.
Okay, that's great. And Dr. Yoba, I think we've noted this. I definitely will connect with Dr. Mona and reach out to other people here who are in that field and who have expertise in developing these kinds of models, and we'll see how this kind of proposal can be pushed forward. I really love what you described, the collaboration you have in Nigeria between CHAI. Just improving access to chemotherapy in Nigeria. So I thought that was a really brilliant initiative. And I think if that could be translated into Cameroon, I think that's going to be great.
And I think we need to tap into our diaspora and not forgetting those who are back home. Making sure that the radiation oncologists back home, the few that are trained, the medical oncologists back home, the nursing, which is really missing in this field, the physicists that are absent, totally absent. That's why I will not tell you how important the physicist is in all of this. The dosimetries that are absent, we need to make sure, and we also need business planners, those who have done business in this and those who have carried it out. If Sidney can actually link you with people who have done it back in Africa, how they did it in their own country, in Ghana, in Nigeria, and all those things, they would help us with the financial plan and help CHAI a lot. But I personally don't mind. I know several oncologists who are of Cameroon origin here in the US. They are quiet in their different areas, but I know them, who can participate in these meetings and give you an insight into what their cancer center is doing, how sustainable it is, and how we can make this sustainable going forward. So I personally don't mind if it's okay joining some of those meetings and talking with Dr. Yaoba, who is a friend and was my senior too in school. So
yeah, I think that would be great. Thanks a lot. Dr. Eyole Njako.
Okay, thank you, Brian, for giving me the floor. I've been following all the discussions keenly. Kudos to the presenter. He presented well. So mine is not really a question. I just wanted to maybe highlight some points. When we talk of cancers, like the presenter did, most specifically maybe for breast cancer, it's mostly all of us know the triple assessment. So the clinical, the radiology, and the pathology. Now, I back home in Cameroon, being our topic, I don't know if our pathologists have also qualified training, because you see, we need good people to do these ultrasounds and do these scans and all of that, so that they don't tell you maybe a malignant breast mass is a fibroadenoma. So I don't know if we are also really including the pathologists, because they play a very keen role. And then another thing also, it's for example, like for the prostate cancer, most patients who have locally advanced or prostate cancer, most of them, we do active surveillance, and you need to do PSA, which you are supposed to repeat after 6 months or 1 year. So the guys doing these tests, the guys in the lab, how sure are we that if I'm following a patient and these are the values that are giving us, is there any opportunities for them also for us to train them? And lastly, like everybody is saying, I feel like the physicians are the backbone of all of this. Like we are saying, diagnosis or early detection is key. You see, some of them, sometimes a patient comes with gross hematuria and they think it's just an infection. 2-3 years later, we discover it was a bladder cancer. So are the physicians aware of maybe the key signs of all of these cancers we are talking about? So that's just all I wanted to bring on the table. Most importantly, the pathologists. For example, in bladder cancer, sorry for coming again. For example, in bladder cancer, when I do the pathological staging, risk stratification is based on the information the pathologist gives to me. Is there muscle involved? Is there no muscle involved? How far are we sure of these results these guys are giving us? Thank you.
Yeah, thanks a lot, Dr. Njako. Just want to point out that Dr. Njako is, I think, a urologist resident, so he's in training. So definitely looking into the world of bladder cancer and prostate cancer a lot. And thanks a lot for your remarks. I don't know if Sidney or
yeah, I can take this and Sidney may add too. Yeah, the reason is I would just take this. This is a bit. So pathology being, I did clinical pathology back home in Cameroon, for those who don't know. And what I would tell you, Njoko, is that it's a big problem. Sidney and I discussed this. We wanted to talk about things that we can change. Pathology is available, but first of all, resourcefully, our pathology department is strong just in Yaoundé and Douala. And the Central Pasteur is actually the strongest. In the regions, even with breast cancer, we still don't get the progesterone and estrogen level, which is basic. We don't run histochemistry, which is basic. So you cannot even, they're using their eyes to try to differentiate what cancer for what. Your mistake level is going to be 50-50. It's like flipping a coin. I'm sorry to tell you that. Even here during tumor boards, even with histochemistry, even when I find a lung mass, there are expert pathologists from Slum Memorial who are unable to tell me this is adenocarcinoma of the lungs. Not to talk about what happens in Cameroon. It's a field we need adequate training. We need, especially if you're biopsying a secondary lesion, let's say in the liver, and you don't know where it's coming from, it's going to be a very difficult problem in Cameroon. And getting the information, as you are a urologist, bladder cancer is the most expensive cancer to treat in the world. If you've ever heard that, trust me, because you guys keep doing TURPs and TURPs and TURPs and then start riding big cars. We joke about it every day, but it's just a cancer that never goes away until you take out the bladder, if you know that. But there is just so much in what you're going to do as a urologist, depends on what the pathologist tells you. And it's sad. Sidney made a comment which is reflecting, making me to change the way I think. I've always thought about no tissue, no issue, because I'm in the US. I say that, or no meat, you don't know bone. You are not going to give anyone any form of cancer treatment without getting a diagnosis from a pathologist proving. But we're living in a different world in Cameroon. We're living in a different setting. There are many things that will look like cancer, behave like cancers. Even when the pathologist says you have to go ahead and try to offer a certain form of treatment. We cannot change our pathology department in one day. We need education. We need to send them to school. We need continuous education. We need to valorize that specialty for medical students to know how important it was. I did clinical pathology because I'm sorry to say it. I loved, when I was in Cameroon, I wanted a specialty that I'm just going to sit in the lab, enjoy myself, chill, okay, and then make money. Now going into PSAs, the problem with PSA is that, as you all know, it's also one of those ELISA tests. You need a lot of them in order to run them effectively in a small lab. So most of the time, specimens are gotten and frozen and kept in the fridge. I'm just giving you the details of how it's done because I did it while in Cameroon. We keep about 20 specimens in order to run them. They decay over time. And at times, those values may not make sense with what you're seeing because of those things that are happening because we're low volume centers. And another thing is because doctors are not requesting for it as frequently as possible. Let's say if you're in the regional hospital in Limbia, you don't request for it frequently, they will not have enough specimens to run them. They have 96 wells, they're going to destroy those wells when they're running those tests. You cannot run one test to do one test for one patient just to make sure. So they need several samples. So at times those tests are not, but they are well done if they are well calibrated. Kenji is going to tell you our problems with our labs is quality control. Quality control, there is no internal and external validation that is being done in most of those labs. And you cannot even tell how good any of the ELISA tests, if done out of you don't know about it, just labs in the quarter or labs somewhere else. So it's a big issue that I want to be having a positive mindset as we all started, like Sidney, that we're going to educate people, we're going to train them, we're going to mentor them, we're going to make sure pathologists. I have had 5, I told Sidney this, I've had 5 breast cancer cases. None of them had ER/PR positive state in their pathology, and they all have died. And they all were treated with chemotherapy. And later on, when the specimen was sent to France for one case, this child was progesterone and estrogen positive, died without ever getting hormonal treatment. Without ever getting hormonal treatment. It made me cry because this is malpractice of the century. How did she get to the point of getting chemotherapy without even initiation of hormone? Hormonal treatment would have kept this young girl for more than 20 years, for more than 10 years, even with metastatic disease, if her disease was not aggressive. So pathology is actually still, I'm an oncologist, but pathology is a cornerstone we should not forget. We know we didn't talk a lot about it today, but we know it's important. Sidney and I, we work based on those results that are sent to us. But if we cannot do it, why should we do? Should we start complaining? Should we still keep on complaining?
Yeah.
If it looks like breast cancer, if it backs, and Wagus is still, even if it's a fox, it looks like a dog, let's call it a dog and try to treat it. So,
absolutely.
Sidney, please, over to you.
No, absolutely.
Yeah.
Yeah, absolutely, Mono. I 100% agree with what you just said. Let me give a hypothetical scenario. A 45-year-old lady in the prime of her life and doing well, has a good job in Ebola, is doing very well, discovers a 2 cm lump on 1 cm lump on clinical exam, okay? And she gets sent from Douala to Yaoundé for pathology, and she can't get a pathology done. But she knows a great breast surgeon in Lakentini who can come in and pick up that lump. As a patient, what would you do? Sit back and wait for that pathology that might never come, or go ahead and try to see if you can get that lump removed, given the size, so 1 cm lesion. So it's probably this height. Now we're looking at probability, and then obviously knowing that right now we have radiation therapy in Cameroon. So just as a hypothetical question, if I was that patient, I would not do nothing. I will not sit back and wait. If you have money to go to France or Germany, then fine, but 99% of patients cannot. So that's the case for breast cancer. Let's look at lung cancers, okay? Like Dr. Mono said, if that lesion is in the upper lobe, it's speculated, it's 3-4 cm, and this guy has a 20-pack smoking history. Hands up, that's 99% is cancer. So in that case, path is not even, you don't have to wait for path. Here in the US, a lot of times, it's not uncommon for interventions to be done even without having the full picture, just because of the urgency of the case. So it's not unheard of. Now, obviously, you have to make sure that all resources have been exhausted. And then you look at this case and say, if you wait and wait and wait and wait and wait, and this lesion, before you know it, people have with this little lesion, before you know it, it's got a subcutaneous, it's not breaking through the skin. Then what happens? You're like, oh my gosh, it's a cutaneous metastasis. Why did I wait? So again, that perfect being enemy of the good, we should be able to apply some judgment and a case-by-case basis.
Yeah. As you said, let the perfect not be the hindrance for the good. It's now a little thing I'm thinking about. I had always been very, how do I call it? Very academic in the way I wanted to with cancers, but you know, we're working in a different environment. So
absolutely,
it's going to be difficult. Like the urologist said, they have a lot of problems. Even knowing which patients to monitor with prostate cancer, if I want to be academic, is a big problem in Cameroon, because how many urologists get a Gleason score? In the first place, even with localized disease, which they are sure of, to be able to say this is Gleason 1, 2, 3, 4, I'm going to monitor. This is a patient who is elderly, may die of something, rather than Gleason 10. You don't get that all the time, even from Central Pastor, I'm sure.
Absolutely.
The Pule is going to tell you that. And the aspect of not getting that is not the ideal place to practice, but we don't want to. I practiced in Cameroon. I've always told those who trained here, it's difficult to practice in sub-Saharan Africa. It's a different kind of medicine. You have to adapt to that kind of medicine. You cannot just copy and paste without adapting.
Correct.
Yeah,
great. So interesting conversations here, and we're happy. We will be coming to the top of the hour soon, and I want to introduce Dr. Jean-Claude Kate. Dr. Kate is one of our founding members of the Cameroon Town Hall for Healthcare Professionals, and recently he has joined the moderating team, and going forward will be one of our co-moderators, and he has a question as well. Hi, Dr. Kate.
Yeah, thank you very much, Elvis, and thank you very much, Sidney. Very interesting presentation, discussions. One thing I got from your presentation was that statement that Muno has been holding on to as well. I think it really hit me. And also just your passion in your presentation was very contaminating. And I just want to comment on the issue of data. I don't know if Dr. Yauba is still on. I've been looking for him on my screen. I have not seen him. I wanted to find out, and this is an open question to some of the doctors who work as district medical officers. When we look at the district health information system that exists in our health system, that now has been deployed, I guess, throughout the national territory, is it not possible in that system to input data about cancers that are seen at the district level or at the regional level to try and palliate for the issue of the cancer registry, which we know is no longer on topic in Cameroon? I think this was a project that was spearheaded by now Professor Orok, back in the days when he was at the General Hospital. But since he left, I'm sure we've not heard anything about the cancer registry. So maybe this is an open question to some of you. Martin, I can see Kitty, who I know worked at the district, and some of the other district guys here. Yes, they are ES2. That's it. So my second thing, which is now a question around maybe to Dr. Muno and Sidney, who are hands-on in cancers, about risk prediction for cancers. As a researcher, I know we're talking a lot about prevention, and we know that some of these cancers have a very strong genetic component. Breast cancers, for example, prostate cancers, for example. I know this may be still far-fetched for the Cameroonian society, but we know that genotyping is getting cheaper and cheaper. Is this something that can be very interesting for us, especially that most of these cancers, they seem to be highly aggressive in Black Africans, especially Black Africans living in Africa. So I just wanted to get your ideas on that. I know you guys are one, for example, genotyping cancers and treating cancers should be things that you guys do in the US and in developed countries. Thank you.
Okay. So I think the first part of your question was not directed at me, but it was directed at those who are back home. And I think I work back home in the district, so I can actually answer. It's easy to integrate it. And I think they have integrated it, as I said, back 11 years ago when I was still in the district level. There were efforts to put in place to integrate the most common cancers in Cameroon into the district health system surveillance, which was in place. Then we used to go for meetings every day, talk about big things, big books like this. And the problem is that in Cameroon, those things, when the data in Cameroon, emphasis is made on it when they want to use it. Even when it's collected, nobody analyzes the other rubbish that is added to it. So even if it's there, those who are reporting know that it's not important, so they don't look for it because nobody's going to penalize them for not doing it. The district medical officers will not. I know several district medical officers are present here. Dr. Sir Bennett, I don't want to put him on the spotlight. There are several of them who are here. They will tell you what they are laying emphasis on. And they drive the goal of the public health department is driven right down to the district level. So it could be there, but most of the time, no one is collecting it or no one is laying emphasis on it because the budget is not there. And there is no penalties or no drives actually for those who don't collect it. It's easy to put a 0 there than to look for your registry and put a 1, even if you saw a breast lump. It's easy to put dash, dash, dash and fill it quickly. I've done it before, so I know how it's done. That I'm giving you a fact. Now, integrating it and penalizing people, or not penalizing, I don't want to use the word, or incentivizing, could be something that Chai can do. Yahuba knows how to do that. They can do a lot of that. They did that with HIV. They did that with child HIV and access to drugs. Now, going to the second part of your question. Before a child has to fly, he has to walk, he has to creep. Creeping is better than walking and flying. The genetic platform in Cameroon and Africa is improving as a result of COVID. We can use the PCR machines to do the same things. We can use next generation sequencing tools that are getting available in Kenya and in Ethiopia and in South Africa. South Africa has a ton of them. In order to sequence genes, we can do testing for BRCA for both those who have breast cancer, those who have PARP2, BRCA1, BRCA2. We can do that for prostate, breast, Lynch syndromes, all those things we can search for them. But if you go into even breast cancer, it's not the majority of cases. It's still the minority. And most of the time, if you're a good clinician, you're going to pick it up. Mother had cancer, daughter had cancer, grandmother had cancer without skipping a generation. 80% of the time, that's either a BRCA1 or 2 gene or related genes. Now, Lynch syndrome, same. You have things like MEN1, MEN2 that you find multiple cancers in families. Those are all things we can do, but there is something, I don't want to go into controversy. We'll have time to talk about cancer. As Sidney said, we want multiple of these topics in the future because there's a lot we'll talk about. There is diet and nutrition. We know today, I'm sure it's data that most of you don't know. If you don't look for something, you'll not find it. We have prostate cancer more than white.
Yes, we have 2 more minutes to take.
We have melanomas more than white. We have just colon cancers more than white. Our intestinal microbes are very important. There are just so many other factors. There are some modifiable factors and non-modifiable factors. So Elvis, this is a topic that we can talk. We'll continue in the parking lot, but this is a topic that we can talk about for days to come. So I think Sidney and I would have several sessions. We'll be shy to talk about cancer in the town hall.
Yes. Sidney, any other comments from Kate's question before we take the last question from Nicholas?
Well, yeah, no, I think basically, yeah, like Muno said, sometimes you gotta crawl before you can fly. Yeah, I am not an expert in gene sequencing or in genetic sequencing. But what I can tell you is that if you give me a stage 1, stage 2 cancer, I will treat it, and you're gonna go home happy and smiling. So yes, I want to focus on treating those people that we catch early, and also being mindful of the fact that it's something I forgot to mention about some innovations and things that can be done right now for basal cell. Now, basal cell is not very common in Cameroon, but for those who don't know, they're actually literally pills that are 99% effective. That you don't have to, there's no specific not targeted therapy, right? You don't have to do any sequencing. But as long as it's basal cell carcinoma, it's 99% effective. So I really want to just thank you guys for listening to my talk, and I'm available. Hit me up anytime. I'll be able to answer any questions, and I'm looking forward to this town hall making some strides in Cameroon for cancer care. Thank you, guys.
Great. And Nicholas, you have the floor for the last question for today.
Good evening, everyone. Thank you for giving me the opportunity. Thank Sidney, good day to you. I know it's a good day. I just want to, it's not a question, I just wish to make some comments or throw in some contributions. The first one I would like to make is on the pathology services in Cameroon. We know that the problems we face with pathology services in Cameroon is similar to other regions in sub-Saharan Africa. I had the opportunity, I was doing some research work at Cameroon Oncology Center in Bikoko. We had the opportunity to analyze the pathology reports or the breast cancer cases over a 2-year period. Our aim was to characterize the pathology reports in terms of their quality. The quality we use characteristics such as histochemistry that was performed on the samples, the tumor margins, and lymph nodes. To our surprise, we realized that out of 592 breast cancer cases that were seen over a 2-year period at Cameroon Oncology Center, only 28.7% had pathology reports. Out of that percentage who had pathology reports, we noticed that only 2.5% of the patients actually had the expected complete pathology reports that are necessary for oncologists to make appropriate treatment decisions. So as some were talking about pathology services in the country, it's an area that really needs to be improved because most of the reports are actually not reliable. And I think digital pathology services will also help because at times we realize that you will need a second opinion or to repeat a biopsy, but the slides are usually not available. So digital pathology service will help fill this gap. Then the last guy was talking about cancers. We also realized that some of the cancers that was communicated by us that we see at Cameroon Oncology Center, especially head and neck, are more aggressive than those in the US. In November 2022, I traveled to Yaoundé to meet the deputy director, that is Dr. Nchinda, at the International Reference Hospital, that's Chantabia Foundation for the Prevention of HIV and AIDS. We did talk about some sort of research collaboration, and one of the point was that we should now try to characterize cancers in the country because of the rising incidents, that we should now actually start looking, it's a good idea to start looking at nutrition to see where the problem is actually coming from, because nutrition could be a contributing factor. Thank you. Because of time, that is a small contribution I will make.
Yeah. Thank you very much, Nicholas Ade, for the amazing work you're doing, and thanks for your contribution, which was not a question, but a contribution. Thanks so much, and we are so excited to hear how you added your emphasis on the problem of pathologies in Cameroon. I think that is a very important area. We all agree there is need for capacity building. Thank you, ladies and gentlemen, for your time during this session. The topic was improving cancer care and reducing mortality in Cameroon. And our guest was Sidney. Thank you so much for a wonderful presentation, and you kept everybody really alert till this moment. We've spent 2 hours together, and you started by asking what we should be able to do to close the cancer care gap in Cameroon. and you pointed out the need for cancer prevention, cancer screening, cancer diagnosis, and cancer management. And of course, you mentioned that study predicts cancer deaths in Africa could double by 2040. And some of the reasons you gave was because of the fact that we now live longer, and also because of urbanization. Sidney said there is the reason why we care so much about cancers is because, you know, early diagnosis of cancer makes it curable. And that is why we have to care so much about, you know, early diagnosis. Also, because we're in resource-limited areas, Sidney says, if we can diagnose early and cure it, it's easier for us, because treating late stage of cancer could be more challenging for resource-limited countries. So our goal for addressing this issue today was, first of all, to look at how this can help us reduce mortality, and how it can also reduce the burden, and also the curative intent and the palliative intent. That was all why we put this subject to discussion on what should we do today. And Sidney said people should take advantage of wellness visit, during which doctors in Cameroon could use it to initiate conversation on cancer prevention. He emphasized the need for us to encourage and dissuade people, or to dissuade people from smoking, using all the kind of scare tactics that has been used in the US, because he also mentioned that though the beauty of cyberknife technology, cancer caused by smoking cannot benefit from such an innovation of technology. And in helping us just look at screening, Sidney said, though we do not have those really innovative technology like the PET scan and other really high-tech screening to cancer screening tools, we should make use of what is available in Cameroon in terms of screening and even treatment. He put to screen the Mayo Clinic calculator that we could also take advantage of, but also Sidney wanted us to look at the fact that doctors in Cameroon first have to educate themselves and know what services are available in Cameroon, so that they should speak as trusted authorities when they are giving advice to their patients on what treatment decision or screening decisions they should make. Sidney called on the diaspora to find at least a doctor in Cameroon and do a kind of preceptor program that could also help kind of close the gap in terms of knowledge. Most solid cancer won't kill you. Metastatic cancer will kill. So that's why all through his presentation, he emphasized on the need for early screening. Sidney said cancer is never an emergency, so we have to diagnose it early. Breast cancer, for example, as he mentioned, has a 99% chance of survival if caught early. So why not screen? So we have to do two things. Either we sponsor screening campaigns or awareness campaigns, or we participate in them, because these are the events that help our people back home learn about the importance of early diagnosis. And of course, he understood that though he's presenting from a point of what exists, the bigger things that can be done, despite the fact that we might not have all this, he said, do not let the perfect be the enemy of the good. Let's take advantage of all what we have and make good use of it. And of course, one action at a time can help us reduce the cancer burden in Cameroon. Ladies and gentlemen, this is what I was able to capture for you today. And thank you once again for dialing into this session. I hope to see you again in a fortnight yet for another interesting session.